Okay, well, good morning, and thanks to everybody for coming today. We're glad to see a nice turnout. In 2012, the CDC reported 259 million prescriptions were written for painkillers. That's enough for a bottle of pills for everyone alive in the United States at that time. 46 people a day today, currently, are dying from overdose of pain medications. And if I told you 46 dolphins were beaching daily in Florida, you'd be very concerned, and that would be front page news. But the deaths from the prescription drugs are not front page news. Now, how many people here use the PDMP or prescription drug monitoring site on a regular basis? Well, it's really good to see. And for the fellows and ladies that don't, I'm here to try to convince you to do that. I'm a graduate of Temple University School of Pharmacy in Philadelphia and the Philadelphia College of Osteopathic Medicine. I practiced family medicine for 38 years, having retired in October of 2013. I now work on a voluntary basis with MATFORCE. MATFORCE is the Yavapai County Substance Abuse Coalition. We are composed of people from all aspects of society, including law enforcement, the legal profession, the medical community, and educators at all levels, as well as members of the faith-based community. Our goal is prevention through education in dealing with substance abuse of all types, including tobacco, alcohol, street drugs, and prescription drugs. Our school speakers are now starting in the kindergarten level. Last year, we were at the 6th grade level. This year, we're down to kindergarten. We now have drug take-back boxes in all our police departments in Yavapai County, and you can see a list of those in your area if you go to the Arizona Criminal Justice Commission website as well. Now, we were influential in convincing the two large hospitals, Yavapai Regional Medical Center in Prescott and Prescott Valley, and Verde Valley Medical Center in Cottonwood, with a total of 4 campuses, to change their emergency room protocols with respect to prescribing controlled substances and treatment of chronic pain patients in their ER. These changes have resulted in a safer work environment for the staff, improved patient care overall, and increased and improved referrals for substance abuse treatment as a result. They use the PDMP on a daily basis. Changes have been adopted by the house staff in Verde Valley Medical Center as well, also in reducing the number of prescriptions given to patients when they discharge them. MATFORCE has been working on the governor's prescription drug abuse and misuse initiative since June of 2012. We actually started this project in June of 2011, and we were directly involved in the development of dispensing guidelines for pharmacists here, emergency department prescribing guidelines, and lastly, opioid prescribing guidelines for practitioners, which came out in November. All these are published by the Arizona Department of Health Services. Similar guidelines are available on the DO website. None of these guidelines are presently mandatory, but I've been advised by more than one attorney that guidelines have a tendency to become standard of care after they're published. Now, I gave you some handouts today. I gave you some information regarding some websites. First is the Arizona Board of Pharmacy website. At this site, you can get directions for enrolling and using the PDMP. The site also gives directions for a delegate that you may name in your office to register for and use the site and get the information desired, saving you the time in doing so. The PDMP gives you complete information on patients' use of controlled substances, amounts, dates, etc. Now, to date, only a small number of delegates have registered for this site. However, we hope that that's going to increase. Use of this site by your delegate is not a HIPAA violation. The information is no more HIPAA violated than an X-ray that comes in or a lab test. Number 2, I gave you the Arizona Criminal Justice Commission. If you click on the icon for RX Initiative, you'll see a large amount of useful information detailing what has been done thus far for the governor's initiative. There's also a lot of information you can download for your own use, including the pain management pamphlets that I gave you today. You can brand these, have them printed, and brand them with your own name if you decide to use them. The pain video that I showed you previously and the pain pamphlet can be used to explain your position in treating pain with your patients. Number 3, I gave you the Arizona Board of Osteopathic Examiners. If you click on For the Public, you'll get a lot of useful information for your practice. Again, pamphlets that you can download, etc. If you click on For Physicians and then Guidelines, You'll be able to view the opioid guidelines which have been published by your board, and they've been up for over a year. Now, a review of those guidelines will show a resemblance to the ones published by the Arizona Department of Health Services. Use of these will enhance safety for you and your practice as well as your patients. I gave you the MatForce website. You can go there. A lot of useful information again, a lot of pamphlets, things that you can distribute to your patients and an aid to help you treat them. All that stuff is free. All you have to do is request it and we'll mail it to you. Now, use of the PDMP is considered standard of care by the DO board and major malpractice carriers in Arizona. It's noted to be the foundation of care in helping to prevent abuse and misuse. It also may serve as a way of identifying addictive behavior and enable you to offer intervention to those patients requiring it. The prescription site is now on a 24-hour reporting basis, meaning that there is no longer a 5 to 7 day lag between filling a prescription and having it show up. Using the PDMP should become a part of your treatment of chronic pain, just as a hemoglobin A1 is now a part of a diabetic's treatment evaluation. It seems clear from various reports in the medical literature at present that chronic pain must be treated with a variety of measures, and patients need to be closely monitored with respect to the use of opioid medications, as you will hear later fully in this educational presentation today. By the way, the VA just appropriated $21.7 million to study alternative methods of treatment because they realize, as we all knew, that opioid use by the VA and abuse is out of control. MatForce has been and will continue to try to increase the number of practitioners using the PDMP. At present, 32.4% of prescribers and 61% of pharmacists are using it routinely as of January 1st, 2015. If you have not already, you'll soon be receiving a report card indicating your prescribing habits and comparing you to physicians of similar specialty in your location. If you're named as an outlier, you should review your charts for documentation and completeness, etc., as you will be, again, instructed today by the board. 4 major drugs are included in the report card: oxycodone, hydrocodone, all benzodiazepines, and Soma. Soma prescriptions have dropped off precipitously lately because they're no longer covered by access. Now, no punitive action will come as a result of these report cards, and they are for your information only at present. In the future, this is subject to change as the information will be made available to various licensing boards to use as they see fit. Also, the JAMA article in your handout indicates that states that mandate the use of their PDMP, Kentucky, New York, Florida, Tennessee, and Ohio, are reporting a 50 to 75% drop in abusive behavior. Also, become aware of the term morphine equivalent daily dose, as this will be reported when you look up a patient's report on the PDMP. 80 to 100 is okay. Over 100 a day, you're going to run into trouble, and you may be notified by the board that you're hitting a peak. Now, there's a spreadsheet covering the 4 named drugs and totals for the last 2 years in your handout today. The numbers are in millions, but remember, the USDA now uses the term hundreds of tons to describe the total amount of opioids manufactured, shipped, and dispensed in our country. The United States has 4.6% of the world's population, and we use 86% of the opioids manufactured in the world. Pain management brochures in your handout are meant to be used alone or in conjunction with that video I showed you, and that was prepared by the Arizona Criminal Justice Commission and Drug Free Arizona. I found that brochure online, modified it somewhat, and Arizona Justice Commission approved it. It's now ready for your use if you want to, and again, if you want to use it, you brand it with your own name. These 2 items, if you decide to use them, may serve as a way to open a discussion with your patients about the manner in which you will treat their chronic pain. Now, hopefully your take-home message today should be an improvement and updating your knowledge and safe use of the various drugs available for your patients today. Improvement in the manner in which you may decide to treat chronic pain in your practice safely and efficiently. Increased awareness of the problems one may encounter in using opioid medications and ways to avoid difficulties in doing so. development of improved practice principles to include use of the PDMP and the guidelines that we set forth for you to follow to enable you to provide alternative methods of treatment for your patients while maintaining a good code of medical conduct. As a result of this conference, you should also be aware of the manner in which your state board and the AOMA are attempting to educate you and have you maintain the high standards necessary to provide the finest care we can for our patients. The people involved from the board here today deserve your commendation for their time and efforts on your behalf with all of the conferences that we've had to date. Now, in your handout, I gave you a copy of my card, and on it is an email address. If you have any questions or want to find out any other information or need some information, you can email me and I'll get back to you. This fellow is a representation of what the Arizona Criminal Justice Commission and NAFORS have called me, the hammer. And together, if we all work as hard as this little guy does, then we'll be able to accomplish our goal, which is to save lives and use better alternative methods of treatment. Thank you very much.
I don't know if you all realize, but the board is made up of 7 people, 5 of which are practicing DOs. And one of the many things that we want to do as a board is to not only protect the public, which is our mission, but also to make our profession stronger. And one of the ways we can do that is by education. The things I'm going to be talking about are going to seem very basic to most of you. And I apologize for that. The things that Dr. Hogan is going to talk about are probably going to seem not at all basic, because he gets really involved in the medications and how to use them. But we had to, kind of gear our talk towards everyone. And even though my part may seem really basic, it would amaze you if you came to some of the board meetings at the things that some physicians don't realize. And so we, like I said, we have to kind of start at the common denominator here. And we, as a board, we understand how difficult it is to practice medicine, because as I said, I practiced for many years before I left practice, and every other board member, the 5, are all practicing physicians. And there's really not a more difficult patient than a chronic pain patient, I don't think. So we all completely understand, but again, we have to protect the public. You can see from this slide that the scope of the problem is huge. It's huge around our country, and it's huge in our state. The red line are opioid deaths. And this is from 1999 to 2010. And you can see that the line just is kind of continuing an upward trajectory. And between the years of 1999 and 2007, opioid deaths quadrupled. The reason that that might have happened is prior to the 1990s, opioid use was not really in vogue, and a lot of physicians viewed them with a lot of skepticism. Then in the 1990s, there was a recognition that a lot of people were being undertreated for pain, and there became a significant increase in the clinical value of opioids. Therefore, there was a dramatic rise in opioid prescribing, which led to a dramatic increase in opioid misuse. There were 40 million prescriptions for opioids in 1991, 180 million in 2007. And of course, this coincided with a dramatic increase in opioid deaths. In 2008, there were 14,800 prescription painkiller deaths. And you can see from this slide that for every death, there's all kinds of other collateral damage that occurs. There's more deaths from opioids than the number of people abusing cocaine, heroin, hallucinogens, and inhalants combined. And opioid death is now the leading cause of death in our country. This query was not adults. This was teenagers, 12 to 17 years old. They asked them where they got the opioids that they were using, and you can see that over half of them received them from a friend or a relative, either purchased or free. And we understand that it's important to tell the public about this as well, that it's really important when you do prescribe to patients and when they take control of them in their home, that they are stored appropriately, that they're stored in a safe lockbox, something that only they can get into. We've heard of people going to open houses to look through people's medicine cabinets. And also it's very common for teenagers to go into their grandparents' home or parents' home, friends' homes, and take their medication out of the medicine cabinet, and then they have farming parties. I'm not sure if everybody's aware of what those are, but where they all put the pills all in a bowl, and then you take a handful, and you never know exactly what all you've taken. And there's, of course, a lot of emergency room visits from that use. And of course, a lot of times they're using alcohol and marijuana at the same time. We actually did create this talk prior to getting the grant, but and this book is on the tables. Please take a copy. It's free from us, free from the FSMB, and it's an excellent guide to opioid prescribing. I'm going to talk about 7 principles, and I will go through them each one at a time, and then Dr. Hogan is going to talk about the medications more in depth. So of course, we'll just go through this briefly. Evaluation of the patient, developing a treatment plan, making sure you have informed consent and agreement for treatment, a periodic review, meaning that you'll see the patient regularly, consultation with specialists, keeping adequate medical records, and then complying with laws and regulations. So in evaluating the patient, we all know that it's really important to take a good history. You should ask patients, the typical patient questions that we learned in medical school about pain. What makes it better, what makes it worse, what brought it on, how long has it been there, all of those obvious questions. But then also ask them about collateral damage. Collateral damage would be how the pain now affects their life, how it affects their relationships, whether they're able to work, whether they sleep. And it's important to know, really the quality of what's going on with them, because you can't imagine the medical records that I review where there's really no information whatsoever. And it's so important that you document where the patient is when you get started. Whether or not they're only able to lay on the couch and they really can't do anything around the house, or whether they're a functioning individual that works and they're just having a difficult time. Make sure that you get old medical records on the patient if they've been seen before. It's really important. You'll be amazed at what you can find out. You can find out if they've been fired before, if they've had difficulty with their physician. But you can also find out what medications that have been tried before. You can ask them that. Why were they discontinued? Were there side effects? And what ones were helpful? What tests have already been done? And when were they done? So do you need to order a new MRI? Do you need to order x-rays? It's really important to talk to the patient about what they expect, because a lot of patients will expect to have zero pain. And we all understand that that may not be necessarily a possibility. So that's a conversation you want to have early on, is, we can make your pain less, but we're not probably ever going to be able to totally decrease it all. You want to know what kinds of other medical problems they might have that may affect their treatment? Are there problems that may make you have to decrease their dosage? Do they have kidney or liver disease? Do they have sleep apnea? A really important question. Is there a legal or protracted insurance process? Because we all know that sometimes when people have this, there is a little bit of a secondary gain, which makes taking care of them much more difficult. A substance abuse history of the patient or the family, because we all know that it does tend to be familial. Psychiatric history. And the reason that you want to know about a psychiatric history is that these patients are very difficult. And then a social history, including a criminal record. A criminal record, really important, because we all know that drug abuse is rampant in our prison systems, and it should be a red flag to you that you may want to look for abuse or addiction. The physical exam that you do on the patient, I give you a lot of leeway on. It really differs on a case-to-case basis, but your exam and the studies that you order should be proportionate to your diagnosis. Make sure that anything that you order is documented in the medical record and that the results are available. So in other words, if you order an MRI, please make sure that the patient does follow up for the MRI and that the results are in their medical record. I do, and the board feels that it is a really good policy to make sure that the patient has at least one really thorough physical exam and history on the chart prior to instituting any medication. And we talked about this treatment plan, your goals for what where you want the patient to be. So the traditional 0 to 10 pain scale perpetuates the misconception that 0 pain is possible. We've done kind of a paradigm shift in the last few years in that we're now having people ask about function. And again, we talked about that earlier, about how the patient, whether they're able to work or not, and what they're able to do around the house. That's really an important concept here. If you don't get anything else today out of the whole talk, remember function. And you should ask the patient about that every single time that they come into the office. Really insignificant pain score reductions. So from a 4 to a 3 might not seem like a significant reduction. However, if the patient can now function in a way that they couldn't before, you realize that what you're doing actually is helping them. And it's really important. Another important thing is to look for pseudo-addiction. Pseudo-addiction is where it seems like the patient might be displaying addiction behaviors, but it's just that they're not really treated well enough. They actually needed a higher dose of medication. And one of the ways to recognize that is addiction leads to dysfunction, while pain relief should improve their function. Again, you should ask them the 0 to 10 pain scale, but you also, more importantly, should ask them about their function. And again, on your treatment plan, make sure that you document any diagnostic evaluations, laboratory that you're going to do, and make sure that it's actually in the medical record. Document your referrals, your consultations that you may want to get, whether it's to physical therapy, to a orthopedic specialist or a spine specialist, or even to a pain management specialist or an addiction specialist. Please document that you plan to send the patient for that, and then make certain that they follow up with that appointment and the consult is actually in your medical record. So let's talk a little bit about the informed consents. We call them agreements now. The thing is that these can be used as an informed consent if you want to put them together, or you can have two separate documents. It really is up to you personally. But the things that you need to make sure that the patient understands is the side effects of the medication that you are talking about using, the fact that they will become tolerant and there's a possibility that they will have a dependence, possibility that they will become addicted. Talk about the drug interactions of any other medications that they might be taking and the possibility of oversedation. Talk to them about the fact that they should not drive a car or operate any kind of a motor vehicle while they're using the medication. And of course, talk to them about the benefits that they may have. Please list the number of medication, the number of tablets that you give them each time that you write the prescription in your medical record, along with the dosage and the name of the medication. Talk to the patient about your policy on refills, as well as what happens if they lose their medication or it is stolen. Specific reasons for changing or discontinuing opioid therapy, including violation of your agreement. So that's something that you should talk about up front so that there are no surprises to the patient when they call you for the 5th time and they have lost their prescription again. These controlled substance agreements are really good at making the patient a partner with you in the process, which is important. It clarifies their roles and responsibilities in the medication. For instance, locking it up, making sure they know where it is, and if their medication is locked in a safe place, it would be very difficult for it to be stolen or lost. It also serves as a motivational reminder about the goals that you have that you've developed together. And it, again, serves as a foundation for later decision making. So for instance, if they violate the pain contract, it really should not be a surprise to them if you terminate giving them pain medicine. Talk to them about just having a single prescriber and possibly even a single pharmacy. So periodic review. This will be that you see the patient back in the office on a regular basis. Most people that are treating chronic pain will see them once a month. Make sure that appropriate lab is drawn routinely so that you can check their liver and kidneys, and make sure that that's documented in the medical record. Urine drug screens should be performed regularly. Again, this is really up to the discretion of the provider, but it's really important that they are done and that the results are in the medical record. The other thing that's really important, I'll digress for just a minute. I do not want this talk to be a way for people to go home or go back to your office and just go through the motions and do urine drug screen check, PDMP check. You have to look at the document. Very often I am looking at these charts, and yes, the doctor has asked the patient to do urine drug screens 3 or 4 times, but every single time they do them, they're inconsistent with their stated medications. It really is of no value for you to run these tests if you're not looking at the results. So we're advising you to do this, but we're not advising you to do it to just do a checklist. We're advising you to do it because it really will help you to treat the patient in a way in which you can help detect people that are having an addiction problem or that are diverting. Again, using the PDMP. Dr. Catalico talked about that. It would be a great idea if you had your designee in the office that you're now allowed to do, run these maybe the night before you see the patients, and have them on the chart the next day when the patient comes in. And that way it really doesn't take any time out of your day and very little time out of the day of your employees. It seems to be a great way to do that, and the emergency rooms do it regularly now. And when you walk in with the PDMP in your hand, and the patient is telling you that they don't get medication from anyone else, but you see that there's 5 other people that have given them medication in the last few months, you know, it's in black and white, and they really can't argue with you. The other piece of this that's really important is getting a family member involved. If you're going to be treating chronic pain, sometimes the patients will be resistant to this, but most often, if they're legitimate pain patients, they will have no problem with having a family member come in and talk to you as well. You can glean a lot of information from the family member that you might not be able to obtain from the patient. For instance, especially about function, because I think that patients may exaggerate their function one way or the other. If you speak to someone from the family, you might find out that they're sleeping all the time. And obviously that would lead you to believe that maybe the patient's over-medicated. It's really important that each time that you see the patient, that you talk to them about their function, about what has changed since you saw them last, and if they're able to do anything more than what they were before. Please document if you change their medication, if you increase their medication, or you change it to a different medication, please document the reason that you did it. Your medical records should look like a book that someone else can read and see exactly what happened with that patient all along the time that you're treating them. Then revise your controlled substance agreement to reflect any changes. And these are times for you to sit back and think about it and determine if you think the patient now needs to be referred anywhere else, like to a pain management specialist or something. And again, you should always talk about or ask about side effects of the medication that the patient's taking. Common side effects that can occur, as you know, with the chronic pain medicines, nausea and vomiting, those tend to resolve. Sedation can resolve somewhat, as long as they're not too sedated. Constipation is the one thing that doesn't usually resolve very well, and it's something that you should talk to the patient about. They should be aware that this is going to be a problem, and you should start early on with modalities to help them prevent the problem from happening in the first place. And these actually were given to us by the FSMB. They're pretty good documents that you can copy off and use in your office. You could hand these out to your patients about not giving their medication to other people and not taking medication themselves unless it was prescribed for them, and not to stop taking it without talking to you first. And the obvious, don't break it up, crush it, snort it, inject it, and don't drink alcohol while taking it. This is about, you know, storing the medication in a safe place away from children, reporting side effects, and then when to call 911. These are, again, really good to hand out to the patients. And this kind of is a good overview for the patient and their family about what would be an over-medicated warning and when they should call you, and then the difference between that and possibly overdosing, when they should probably call 911. Because, I mean, to us it seems really second nature, but to lay people it really isn't. And they really don't always know exactly, you know, when they should call you or when they should call 911. This talks about how to dispose of their medications. There's a lot of controversy about whether or not you should flush it down the toilet. The main thing is that we are starting to have a lot more places that are able to do drug take-backs, and there are some laws in the works that are talking about having drug take-backs in the pharmacies, which I think would be a great idea. There's, every once in a while you'll see on the TV advertisement for a community take back in your area, and that's a good time for patients to get rid of medications that they don't think they'll be using again. The tragic case that that I was thinking of earlier was a patient that was taking, she was a kind of a new patient to this doctor, and he gave her OxyContin, and then he also gave her methadone. And what his intention with the two medications was that she would take the OxyContin as he directed it, and if that didn't work, she would then fill the methadone and take that. Well, the patient, he didn't write that down. He wrote it in his medical record, fortunately, but he did not write it down for the patient. And she was very unfamiliar with taking these kinds of medications, and so she filled them both. And the pharmacy got sued as well because they should have probably not filled them both. She filled them both, and she took them both. And it was one of those, when you call 911, because the family found her the next morning, and she was already deceased. Querying the PDMP is really important. It seems like most of you are using it, which I think is excellent. We're really happy to see that. But Dr. Catalico was telling us that only like 32% of all providers in Arizona, that would be everybody that can prescribe, is using the PDMP, that's ridiculous. Because the PDMP can tell you, if you haven't ever used it, it tells you every person that has prescribed for the patient, exactly what they prescribed, how many they prescribed, the dosage, what pharmacy they bought it at. It tells you everything. And the reason that's important is that if you see a patient who's gone to 5 or 6 different pharmacies and they're not even close to each other, and they've gone to several different providers, you can be certain that there's a problem going on. Don't know for sure what it is, but there's a problem. I mean, we definitely want to stop diversion in our state, but we also want to help patients that are addicted. And every state in the country now has a PDMP program except for Missouri. Apparently there's a physician legislator there that's against it for some reason, and they cannot get it passed, and we don't know why. So let's talk about the urine drug screens again. It's really important to get these on your very first office visit if you're intending to prescribe for the patient. And the reason is, it's going to tell you right up front if they've been truthful with you about what medications they said they were on when they came in. It's going to tell you if they're taking any illegal substances. It's a very important tool. And of course, you want to obtain a urine drug screen regularly. I have another really horrible case that happened just recently where a mother sent a complaint into the board because her daughter died. And the reason is that the daughter was a drug addict. She was going to this one particular DO physician and getting OxyContin and Xanax from him, or oxycodone and Xanax. What she didn't tell him is that she was also going to a methadone clinic. And that's the really scary thing, you guys, is that methadone clinics do not get reported to the PDMP. We have tried to figure it out, and we think the reason is that it's considered dispensing or administering, I mean. Like you're administering the medicine because I think the patient takes it right there, right? That's the only thing I can think of why it wouldn't be. I really hope that that law is changed at some point, because the reason that this gal died was like intoxication, drug intoxication. And what would have been the one way he could have found out that she was doing a methadone clinic? Because he didn't know, she didn't tell him, and it's not on the PDMP, the only way he would have known would have been if he would have done a urine drug screen on her. Unfortunately, he did not. So he did not know that she was also taking methadone, and she overdosed and died. The thing to know about urine drug screens, though, however, is that this sample will tell you that only 26% of the time are patients usually taking the drug as they're supposed to. So if you get a urine drug screen other than what you would expect from a patient, either it's negative or they've got another drug in there that you didn't think that they were supposed to have, it's really important to call your lab and discuss it with them. That's what they're getting paid for. There's a director there. You can call and say, I have this really unusual result. Can you help me with it? Always discuss it with the patient first before you become real accusatory, unless too many things are adding up. Discuss it with the patient, and then, ultimately, unfortunately, a positive result or an inconsistent result is probably an inconsistent result. So these are some of your risk factors that you're going to look for. And again, you know, I know this is really basic for most of you, but obviously, if they have a substance abuse history, if there's a family history, if there's a psychiatric disorder, people with psychiatric disorders have a 3 times greater risk of substance abuse than other people. And then obviously if they have other things going on in their lives that make them at risk, difficulties, sexual abuse, difficult social situation. So your red flags of aberrant behavior, and again, I know that you all have seen this, we've all seen this patient, but you would be surprised at the number of medical records that I look at where I see this incredible escalation that I can see it on paper, but the physician, it just went right over their head. The patient is asking for more medications. A lot of times they will run out early. That's another really big sign, is because what they're doing is they're taking more than they're supposed to. They don't want to change the medication, they just want to increase the dose. And again, this deterioration in function at home or work, really important to get that family involved so that the family can tell you, well, you know, he's sleeping all the time, he's just sitting in the chair sleeping. That's a really important piece of information for you to know that you might not get from the patient. Are they adherent to your urine drug screens? That, you know, so many cases, the patients will refuse to do a urine drug screen. And then they'll come back a couple days later and do one. To me, that's a positive urine drug screen. Because if you can't do it right then there's got to be a reason. If they lose their medication or it's stolen multiple times, there was a case not that long ago where the patient literally had either lost or had his medication stolen 5 months in a row. And the doctor kept writing the prescription. And of course, we know that the majority of our patients are legitimate and they do have pain, and it's important for us to be able to distinguish. But again, there are professional diverters. These people will not want to present an ID card to you. It's really important because I think it's a good deterrent if you know who they are. Again, you know, from out of town, they pay cash, they request the drug by name, they're allergic to nonsteroidals and codeine, all the things that we've all seen a million times. They show no interest in their diagnosis because they don't really have the diagnosis. They fail to show up for the follow-up appointments. That's another really important, you know, how compliant is this patient? Do they actually go to the specialist that you send them to? Do they actually go for the MRI and the physical therapy? And that's another reason that it's important to document that in the medical record, to make sure that those things end up in your medical record, because it shows patient compliance. It's really important. So know when to refer these patients. Recognize your own limitations. That's, of course, one of the most important things that we learn how to do. But when you decide to refer, do it without delay. If you think of it, you probably should do it. Make sure that you have in your armamentarium several specialists that you feel like you can count on that will call you if they have a problem, and that you can also call for advice. If you feel like you're getting kind of overwhelmed, it's probably time to send the patient to a pain management specialist. Be specific about your referral. Make sure that they understand why you're sending them. Are you sending them because you'd really like them to do interventional therapy, some kind of a injection, or is it that you want to know about the medicine that you're using? Is it an appropriate dose? And then when you decide to terminate a patient, so you don't have to terminate the patient completely if you decide that you do not want to treat the patient for chronic pain anymore. There is another option. You can tell them that you're not going to write for their chronic pain anymore, but you'll still see them as a physician. So if it's a long-time patient, you don't have to actually discharge them completely, but that's up to you. Now, you might want to, if you find that, or you know that they're selling prescriptions, that they're forging prescriptions, they're threatening violence to you or your staff, which does happen, or even sometimes if you find out that they're using illegal substances as well, it's probably a good idea then too. You should try to terminate the relationship or the fact that you're going to use chronic pain medicine on a face-to-face basis if you can, and have a witness available if it's possible, and then always follow it up with a certified letter. So if you decided that you wanted to write a prescription for a patient for 90 days, and we want to talk about the best way to do that, the legal way to do that. It is not legal to sign an undated, blank, or predated prescription form. So you would write the prescription with today's date 3 times. And for 1 month at a time. And then you would write on the 2nd and 3rd prescription, do not fill until, whatever the date is. That is the proper way to write for 90 days so that you're not doing a predated prescription, okay? And you cannot write controlled substances for yourself. You cannot write them for a family member, and a immediate family member would be your spouse, your mother, your father, brother, sister, or any of their children, or your spouse's mother, father, brother and sister, or any of their children. Those are all immediate family members, and the only way that you can write a controlled substance for those people is if there's no other physician in an emergency for greater than 50 miles. So that's probably not going to happen around here. So again, the only way that someone else is going to be able to take care of this patient if they transfer, or for a insurance company or a board or anyone to see what's going on with your care, is with good documentation. And like we've talked, I've hammered it in over and over again, making sure that if you order things, that you have someone to follow up, a tickler system of some way to follow up and make sure that the patient is actually going for the appointment and that the results are in the medical record. If there's aberrant drug behavior, it's really important that not only it is documented, but you document the discussion that you've had with the patient about it. again, on a lot of those cases I was telling you about where the drug screens were positive, there's absolutely no documentation in the medical record anywhere that the doctor noticed or that they talked to the patient about it at all. So if you will document all of these things, it will make it very easy for you, or not easy for you, but it will make it much easier for you to take care of this patient and to determine if there's a problem or a risk. And I call this my universal precautions, because if you do these things on every patient, it levels the playing field. The patients don't feel like there's a bias against them. And again, if you talk to them about it in the very beginning, when you very first start the treatment and you are doing your informed consent and your agreement, it will be there will be no surprises. So in summary, we as board members and as physicians, we understand how difficult it is to treat chronic pain patients. You will not be judged harshly if you're treating patients in this manner that we've discussed, and if you if it's clear what your judgment was, if it's documented well, if we understand what's happening with the patient, and all these things are being complied with, you will not be sanctioned for this. The goal is to control the patient's pain and to improve their quality of life and, most importantly, their function.
One thing I look at is how did we get into this mess with opioids? And I don't know if anyone remembers, but pain became the fifth vital sign with JACO back maybe like 10 years ago. I think it was like in the mid-90s. There was several lawsuits. I know one in California where they alleged that the doctors were under-treating pain, and the doctors were settling malpractice lawsuits. And there's a big fear that we were under-treating people's pain. So the pendulum of opioid prescribing started to swing the other direction rather quickly, and the amount of opioids that are being prescribed is at some of the highest levels it's ever been. And in the United States, I think we're like 4% of the world's population. We consume over 80% of the opioids in the world. So we are incredible, huge users of opioids. So now the pendulum is starting to come back the other direction. We're noticing that people are diverting opioids, they're overdosing on them, so we have to bring our practice more back towards the middle. So I think one of the things that I was thinking about when I was looking at this lecture is that a lot of this seems like it's focusing on providers, as if we're all the problem with what's going on. I think we're probably the easiest target with what's going on, because it's a lot easier to regulate us and monitor us than it is to regulate and monitor the patients that are diverting the medications. And interestingly, the CDC is getting very involved in this epidemic that we're facing right now. And they just published a couple weeks ago a comprehensive review of all of the states and their doctor shopping laws. So there's actually some states where they will go and prosecute patients who are obtaining controlled substances under false pretenses. We don't have that here in Arizona yet, but I can tell already that there's an interest by the federal government to look at taking this back onto the people that are actually diverting the substances. So, we'll kind of stay tuned for that. But if you Google it, you'll find the report. It's very interesting to see which states are prosecuting patients. So I want to talk a little bit about efficacy. So the pendulum swings the other way. We're all wanting to treat chronic pain with more opioids. What is the plus side of that? What are we getting for all of the problems that have been created over the last 10, 20 years? So if you look at chronic non-cancer pain and you want to look at efficacy, there's a rule that I always talk about as the 1/3, 1/3 rule. So for everyone that you start on opioids, only about 1/3 of them are going to tolerate being on opioids in the long term. The side effects of constipation, itching, sedation, all the endocrine effects, People don't like the feeling of being on opioids a majority of the time, 2/3 of the time. Then the other part of the 1/3 rule is that of the people that get pain relief from the opioids alone, they're going to describe a reduction in pain on average of 3 points on the visual analog scale. So if someone has a 10 out of 10 pain, with using opioids alone, your likelihood of getting success is about getting them down to a 7 out of 10. So when I think about, what I want my waiting room to look like in the future, and I think about opioid monotherapy, every patient that I take in, if I take in 10 patients, I'm going to fail to manage their pain adequately 6 times out of 10 just using opioids alone. And even when I do succeed, I'm only going to get about a 30% reduction in their pain. So the data it's there. There's enough data there to support trying opioids, but there's so much stronger evidence in manual medicine techniques, physical therapy, anti-inflammatory medications, non-opioid modalities. So it's important to keep that in mind. I'm just like you guys. I'd like to have a waiting room of happy patients that are well managed, and you can lay your head on your pillow at night and know that you're doing the right thing. And so that's where I kind of want to get everybody at. So we talk about efficacy. The other thing is risk. So as a practitioner who's prescribing opioids, where does my risk really go up with serious adverse events with your patients? There's a couple different studies that have come out recently. One of them in JAMA in 2011 showed that if your patients are taking more than 100 milligram morphine equivalents a day, the risk of serious adverse events is 7-fold. Another big meta-analysis showed if they were taking more than 200 morphine equivalents in a day, the risk of adverse events and death is 400% greater. So some states have suggested 120 milligram oral morphine equivalents per day limit, I guess, if you will, for non-pain practitioners. I think probably the truth is somewhere in the middle between 100 and 200 milligrams. Even my practice that's solely devoted to pain, we try to stay under 200 oral morphine equivalents per day unless there's a good reason to go above it. So that's just something to keep in mind where the risks go up. And the nice thing about what they're doing with the pharmacy database is now they're tracking for the patients. I don't know if you've noticed, but on the reports it actually shows their oral morphine equivalents in a big number on their pharmacy report. So if you're looking at taking over a patient and you see that they're on greater than 100 to 200 oral morphine equivalents, it kind of puts the flags up a little bit that this would be a higher risk patient for you. So when you're looking at starting on patients on a long-acting medication, you obviously want to look back and have they been on a short-acting opioid medication? Have they tried other things than being on opioids? Have they gone to physical therapy? Have they tried osteopathic manipulation or chiropractic care? Other alternative therapies. A good sort of a litmus test is at the point before you start them on a long-acting opioid is to really consider, is this someone I want to manage in the long term? Should I send this patient out for consultation with a pain specialist or a spine specialist? Get another opinion in what to do with the patient's care. So when would you not want to give somebody a long-acting opioid? I think the biggest part is the bottom left one. Is people are at really high risk of not following your directions with prescribing are people that are going to get into trouble on long-acting opioids. So if someone's already if you're prescribing 3 Percocet tablets a day, and then you're going to start them, and they're not taking it appropriately, and they're taking 5 or 6 of them a day, if you give them a long-acting medication, they're not going to get that euphoria in the beginning, and they're not going to understand that, hey, this medicine's being released over 12 hours. If they start taking more of them than they should, it's going to peak and cause respiratory depression, and that's when they get into trouble with overdosing. So one of the big questions you look at when you are going to start someone on a long-acting opioid, and this is, I think, one of the most important parts of the entire lecture, you have to determine if that patient is opioid naive or opioid tolerant. And there's going to be a box and a few more slides from now that basically defines that, what an opioid tolerant patient is. And it's different, the doses are different based on which opiates that they're being prescribed and taking. There are some long-acting medications, and we'll go through it later, that cannot be prescribed to somebody who is opioid naive, meaning that their body has not been exposed to opioids before, and if you put them on those medications, they can have a much higher risk of overdose. One thing to look at too before you continue to escalate somebody on, let's say you've chosen a long-acting morphine and the patient's just not responding to it, there's a phenomenon called incomplete cross-tolerance where patients may respond to one opioid better than others. And so sometimes it tends to increase your worry about if someone's just trying to obtain narcotics from you. But if someone says something like, well, hydrocodone doesn't work for me, but oxycodone does. That really could be a real phenomenon with that patient, because there are some people that respond better to other opioids. So they all bind on the mu receptor, but because of different subtypes, there are patients that will respond better to one than the other. This is the graph that I was talking about that's really important. You might want to print this off later, keep this available to you. But this is basically determining if someone's opioid tolerant or not. And it has all of the doses on there. And at the bottom of the slide, it says for 1 week or longer. That's what they want you to look at. The patient has to be on a minimum of those doses for 1 week. So part of that cross-tolerance and that difference in some people having more efficacy than others is significant in the sense that if you're going to ever rotate somebody from one opioid to another, that second opioid that you're going to rotate them to might be much more potent for that patient than what they're already on. So you wouldn't want to put them on the exact same dosage of what they're taking, because that may be very effective for them and cause more respiratory depression than what you would expect. So pretty much all of the time, you're going to be reducing the equivalent dose when you're rotating somebody to another opioid. I think kind of the safest way is to put them on a short-acting opioid, get them to a level where they're reasonably comfortable, and then that gives you a total daily dose. Let's say you put them on Percocet, for example. They're taking 10 milligrams, 4 times a day. They come back and they're not well controlled. They've got, legitimate pain. They're not a high-risk patient. Then you would look at, okay, they're on 40 milligrams a day of Percocet. What dose of OxyContin, the long-acting version of oxycodone, what dose would you put them on? And that person you could put on 20 milligrams in the morning and 20 milligrams at night. That would be 40 milligrams. So you know that they're already tolerating that. It's within the same type of medication. And then you can still provide them with some breakthrough medication as needed. So there's a couple different approaches to rotating. And there's one where you basically can introduce the new long-acting opioid as you're decreasing the dose of the old long-acting opioid. I'm not a big fan of that method. I think that you really have to trust that the patient is educated and follows your directions. It can be very confusing for people to be taking 2 long-actings and lowering the dose of one. It kind of reminds me of the case Dr. Pra was talking about, telling the patient, okay, well, we're going to start you on some OxyContin, and then you've got another long-acting methadone in there. I think it sets up a more of a risky situation. So usually what we do is recommend stopping the old opioid and then rotating them to the new opioid at a lower equivalent dose.
Is there a percentage down you would consider?
Yeah, we'll get, yeah. There you go. So the answer to this one is typically you're gonna reduce them by 25 to 50%. And there's gonna be some tables I'm gonna show you that shows you how to do that, and there's an online calculator that I like to use because I'm not a big math person. Methadone is the exception to this, and we're gonna go through that. Methadone, if you're rotating somebody to or from methadone, this is probably your highest risk opioid management that you're gonna be doing. A lot of people just won't do it, and they'll send them to a specialist or have them do inpatient. We're gonna get into that later. So when I look at making a decision between the 25 and the 50%, I look at the overall patient status. If someone's on really high doses, then I'll look at maybe reducing them by 50%. If they're elderly, if they're really sick, if they have a lot of respiratory issues, that would be someone I would do 50% as opposed to 25%. And opioid rotation is also one of the tools that we use as pain specialists to keep people's doses down. So instead of prescribing them more and more morphine until they get to 600 milligrams a day, what we do is if they start to get over 200 milligrams, we'll rotate them to another opioid, reduce 25 to 50%, so it allows you to keep that level of opioid daily dosage going down as opposed to continually going up. So on the bottom of this slide, this is what we call a equianalgesic dose table, and this is what will show you basically all the different opioids and what their dosages are. Again, I'm not a big math person, so I use, at the bottom of this slide, there's an online calculator that you can look at that will actually allow you to plug in those different medications and what percentage you want to reduce them by, and it'll tell you pretty much how to do it. There's, for fentanyl patches and for methadone, when you go to this website, there's a lot of different disclaimers. I recommend reading all of them because those are, again, kind of your riskier drugs to rotate. But I think you'll find that these tables are really helpful. Even though they're really helpful, you can still get burned using these tables and using the calculators. So the ones I think that you tend to get burned the most on are the high opioid doses, obviously if they're already over more than 200 milligrams of morphine equivalent. And then in the bottom middle where it talks about interpatient variability. So that's that how they may respond much better to one opioid than another. And it's hard, and that can be hard to predict. So this is the slide that talks about methadone. If 75 to 90%. If you're not doing pain management regularly, I would honestly really avoid switching people on and off methadone, especially if they're taking more than 100 milligrams in a day. There's also some new guidelines that came out a couple years ago. If you're managing people on methadone, they should be getting an EKG every year to look for the QT prolongation. And also with significant dose changes, that you should be, if you're increasing their doses, you should be getting an EKG after that as well. And then there's in a slide somewhere here, it's switching to the transdermals, the fentanyl and the buprenorphine patches. They want you to follow the directions in the package insert, which you can get off the web or I believe in your PDR. I think one of the key things on this slide that I like is when we're talking about treating someone for breakthrough pain, which is pain that occurs maybe only a few times in a day. The dose of a short-acting medication like Percocet or hydrocodone, if they're on a long-acting medication, a breakthrough pain dose should really only be 5 to 15% of their total daily opioid dosage. So think about somebody who's on oxycodone immediate release 30 milligram tablets, the most abused medication that's out there. If someone's taking 4 of those in a day, That's 120 milligrams, you know, and do the reverse math on that. If they're on a long-acting medication, you know, that they would have to be on a massive dose in order to be getting a 30 milligram breakthrough pain, right? So it's, you know, it's something to keep in the back of your mind that if you're converting them from an immediate release to a long-acting, the dose that their immediate release is going to get lowered, right? Because you're putting them on a long-acting, so you're going to be giving them a percentage of what that long-acting dose is. And then obviously you wouldn't want to use a long-acting medication for someone that only has breakthrough pain. This is basically just a summary slide showing the process of rotating somebody from one opioid to another. But this is opioid rotation and starting people just right off the bat that are not tolerant to opioids, starting them on a long-acting opioid is probably where most people get into trouble with overdose and fatalities. Respiratory depression is the biggest effect. Dr. Pra talked about that. It's really nice if their family members are there when you're prescribing them an opioid, especially starting them on opioids. I always talk with them about, you know, watching how they're breathing for the next, you know, day or two, just to make sure that they're not getting too somnolent. Naloxone can be used to reverse respiratory depression. I think a lot of the EMS people now have naloxone, Narcan pens available that they'll be able to inject people that have overdosed. And your people who are really high risk for respiratory depression, obviously the opioid naives, elderly, people with respiratory issues, small children, asthma, and people that are taking benzodiazepines. Benzodiazepine and opioid concurrent use, we're going to get into that later, but that's a much greater risk factor for respiratory depression. Okay, how do you get out of, once you've kind of engaged in prescribing someone long-acting opioids, how do you get out of it if things aren't going well? I have some strategies that I'll go through with you now. So I like what Dr. Pra was saying before, and this came up in some of our small towns when we were doing the lectures, but basically just because you don't want to prescribe them opioids anymore doesn't mean that you can't take care of them for their other medical issues. So, you know, you can say, hey, I think you have legitimate pain, but I don't think that we're able to have a relationship in this moving forward because you're not following the rules that we had talked about when this began. So I'll continue to take care of you for your general medical issues, but for pain, you know, this is going to be your last prescription today. I'm going to give you 30 days worth. We'll get you over to a pain specialist, but that's it. And I think at that point, you're pretty much safe and off the hook. Sometimes they'll try to, you know, come back and say they couldn't get into the specialist and things like that. But I think at that point, it's the really burdens on them. Another strategy aside from just giving them a 30-day supply of medication is I'll taper people from opioids as well, just slowly wean them down. And these are people who basically, you know, you trust them to follow directions, or they're saying the medications aren't working very well and they don't want to stay on them, and you want to get them off the medication, so you start to basically slowly taper them down to avoid the withdrawal symptoms. People that I wouldn't consider tapering, and some people that I'll send just to detox right away, people that I think are a danger to themselves. They continue to self-escalate their doses. They don't listen to you. If I find out that they're diverting their meds, you know, if they're selling them or giving them to their family, those patients I'll usually just send them to inpatient detox. Also, if I have someone come in off the street that comes in for a new consult, no medical records, they're on high doses of opioids, I'll offer to arrange for them to go to inpatient detox as well. People that I tend to just give a 30-day prescription to and send them on their way are people that frequently no showing for their appointments, people who are rude to staff, people who just request a self-discharge. They just say, Dr. Hogan, I think you're a terrible doctor. I want to go somewhere else. No problem. Here's 30 days worth of your medication. You know, good luck. You know, sometimes if someone goes to a dentist for a procedure, they'll get some medication and they won't realize that that's violating their contract. I'll usually give people 1 or 2 chances if they make mistakes. And I think that in this lecture somewhere it talks about basically allowing people to make a mistake. I think people are human, and sometimes these things will happen. Oh.
That's an interesting question.
Yeah. So there's a question of if a patient just wants to self-discharge from your practice, do you have to send them a certified letter? I typically don't. Usually what I do is print the letter for them at that time, and I just hand it to them so that they can take it with them. The other aside from exit strategies, and I think another important thing is what I call foot in the door patients. These are the patients that come in, they're there for a new patient visit, and they're like, Dr. Hogan, I just need to get off these medications. I'm on these really high doses, and I know it. And you know, I don't have any medical records with me, and I've seen 39 other providers this year, but you're the only one who can help me. I read all your reviews online. And then those are good for me because I'm like, yeah, I'm so excited about doing this for you. Here's exactly how we're going to do it. I'm going to take you down by 25% a week, and we're going to make this commitment together. And if it doesn't work, guess what? You're going to go to inpatient detox. Because I'm setting that expectation at that very moment that if they come back in and say, Dr. Hogan, it's not working for me, I'm going to have to go back on my crazy doses. I'm like, well, I totally understand. Some people can't handle this outpatient, so we'll get you in somewhere that can really help you. And that's just something I've developed over time so that they know exactly how things are going to go. And I lay that out in the chart very carefully so that they understand that this isn't easy. It's not easy to come off opioids. And so sometimes you have to go in the hospital to get it done. And then and they know that I'm not going to continue them on 1,000 milligrams of morphine a day. One important thing too I want to point out on this slide, referring to addiction specialists. So pain management and addiction are generally separate fields. You know, pain management specialists like myself, we basically rotate through an addiction center for a month, and that's it. We don't carry X waivers on our DEA licenses. We don't actively manage addicted patients. So if you know that somebody is addicted to opiates, the majority of pain specialists aren't going to prescribe them opiates. And so that person really needs to go to an addiction place, a daily methadone maintenance clinic. So it's going to save you and your staff time to identify them as someone who's narcotic dependent, and then find kind of a place where you normally would send those patients, whether it's a daily methadone clinic or a Suboxone prescriber that's in your area that is certified to prescribe it. I think it'll just kind of speed things up for the patient, and it'll save your referral coordinator a lot of time. And another strategy that I've noticed, like I was thinking about with referral coordinators, I don't know if you guys find this, but there's a very small percentage of patients who take up a lot of time with your staff. And a lot of primary care doctors that I work with are starting to, when they bring in a new patient, they'll tell them, we're going to process X number of pain management referrals for you. Whether the ones I see a lot they're doing this 2. If I send you to a pain management specialist and you don't get along, and whatever happens, happens, I understand that can happen sometimes. I'll send you to one more, but at that point, I'm done sending you to different pain management doctors. And the practices I know that are doing that have been pretty happy because they've found that they've really freed up a lot of time with their staff. So it's something to think about if you're having trouble with patients and constantly coming back to you because they got discharged and want you to prescribe their medications. If someone's on very high dose opioids and you want to taper them off, it's a little bit counterintuitive. You can actually taper them faster than someone who's on lower doses. So you can actually reduce somebody by 25 to 50% every few days if they're on high doses. In order to avoid withdrawal symptoms in a patient, you only have to give them 20% of the dose that they were taking the day before. So, taking someone down 10 or 20% is not going to put someone in withdrawal. they're gonna, and they always say, well, you're gonna put me into withdrawal and I'm gonna make a complaint to you to the medical board. And say, I could reduce you 80%, I'm being nice. I'm reducing you only 25 or 50%. And you're well within the literature to do that. Okay, so key messages for Module 2. Non-opioids first. Be careful when you're rotating the opioids from one to another. You're almost always going to reduce that dose when you rotate them to a second opioid. And I always use the calculators when I'm doing that. I think it's safe to do that. And watch for their total daily doses of medications and warn them about respiratory depression. So Module 3 is mostly about urine drug screening. I'm going to be skipping a lot of the slides because they're kind of redundant, and I want to get into a little bit more of the meat and potatoes of urine drug screening, because we get a lot of questions on urine drug screening. So I'm going to talk about sort of what we do to minimize risk in our pain practice, because I think it really ties in well with urine drug screening, which is an excellent tool to reduce your risk. So if a patient is on my schedule for the next day, whether it's a new patient or a follow-up patient, my staff will pull the day before, they print off my schedule for the next day, and they'll pull a pharmacy board report on all of those patients for the next day. So you can delegate to your staff, one of your staff members can be delegated to log into the database and pull those reports for you. You don't have to you used to have to do them yourself for every single patient. So my staff will pull those reports, and then they'll kind of flag ones that if they think that there's going to be some issues, so that we kind of know what's coming. And then our follow-up patients, they'll look through and see if they're at a point where they need to be urine drug tested. So that way they can kind of get the specimen cups ready and let the patient know when they check in that they're going to be tested that day. So that's kind of the activity that goes on the day before. When they check in for their visit at the front desk, one of the first things we do, obviously, we copy some sort of a photo ID for the patient. We also photograph the patient and save it in our EMR. And there's a couple reasons that we do that. One of the DEA's top recommendations for keeping drug diverters out of your practice is to do that. You photograph them and you put a copy of a photo ID in the chart. Drug diverters do not like to be photographed. And it also saves you from, when someone comes to pick up a prescription, you know who that patient is that you saw. It's not someone that, and we see it like a sister or brother that wants to come in and try to take their prescriptions. And I've had cases like, unfortunately, of people trying to forge my prescriptions and things like that. And it's nice when the sheriff comes in and says, I'm here to investigate this case. And I say, oh, perfect. Let me get you a copy of their photo ID. And let me get you a picture, because then the next thing they'll say is, well, that wasn't me when I came in. That wasn't me who came in. Oh, well, let me print both. Let me print the picture and their photo ID. And it just ties up the case real nicely for the officer, and they love it. So I think if you do that, and I'll guarantee you're gonna get people that will just refuse to be seen and will walk right out your door. And I get that probably at least once a week. Someone does not want to give an ID and they do not want to be photographed. And so for urine testing, we test anybody that on the first visit that wants to be prescribed opioids. We collect a urine sample from them on that visit. We also start to look through the chart and kind of get a sense of whether this is a high-risk patient or a low-risk patient. Our charting system allows us to put some comments in there for when the patient, anytime you open their chart, a comment box will pop up. And we list in there whether we've decided that patient is a low-risk patient or a high-risk patient. The reason for that is that it helps us figure out how often we want to test them, how many chances we're willing to give them if they make a mistake, You know, if a patient comes in and I think they're really high risk, I'll put in there that we're going to take this patient, but we're going to have a zero tolerance for any sort of aberrant behavior. And we tell the patient that. You know, we believe people get second chances in life, but you've made mistakes before, you know the rules. We're not going to be giving you, you know, a bunch of second chances if you can't follow them this time. And they're pretty receptive to that. So for your practice, you'll have to figure out, A, just how much you really want to be doing this, managing opioids, and B, kind of what your protocols are going to be. And you know, none of us are perfect. And I think about, you know, people broke out of Alcatraz, right? The prison that couldn't be broken out of. So these people are going to find a way around your system somehow. It's going to happen sometimes, and you have to be willing to accept that. But if you design a system that is, you know, pretty tight, I think you're gonna weed out a lot of the risk out of your practice. And urine drug testing is a really important part of that. So there's 2 phases to urine drug testing. Does anybody do drug testing in their office, just out of curiosity? Okay. Do you guys send it out, or do you do it yourself? Do you have your own lab? Send it out. Okay. So when I first started in practice, I used to do, when you look at screening, there's 2 ways to do a screening test. And a screening test is either a point-of-care cup, you know, where you see where it's usually like a 6-panel cup. It'll tell you like opiates, benzodiazepines, things like that. The other way to do it is to collect their sample in a clear cup and send it to a lab just for an immunoassay screen. And insurance will cover either one of those steps. I used to do point-of-care cups on everybody, but you know, for me, it seemed like I was getting a lot of false positives for a while, and it creates an awkward situation with the patient. You know, someone that used, you know, Vicks vapor rub, now I'm going to accuse them of using methamphetamines or something like that. So now I've gone to the method where I just collect the cup and we send it to the lab. So on a first visit, you may not know what that patient's exact history is with what they're taking and what they're not taking. But I think that for us, it's created a lot less awkward situations. So either way, though, both methods are acceptable. So you do an initial screen, and then what you need to do after that is it needs to go to confirmatory testing. So this is where it's much more precise. So if it's methamphetamines, they're going to do, you know, specific testing for that. They're going to test for the drug metabolites so that, you know, they can't just crush up oxycodone and put it in the cup and then pass the test. They're going to look to see if there's noroxycodone and other breakdown products of the drug. So the confirmatory testing is a testing where you really can hang your hat on it. And this is done with, you know, liquid or gas chromatography. These are big, expensive machines. Most people have them at outside labs, but you can, if you do a lot of pain management, you can eventually get your own machine as well. Insurance also covers that. Another method that we have available in our office, and I think it has been a great thing for us, is you can also test saliva. So if someone says, I can't produce a urine sample, or what I'll do too sometimes, if I think that they're doing something shady with their urine sample, I'll just collect a saliva sample that day, just without, you know, they won't know it's coming. I'll just say, okay, we're gonna get a saliva sample today as well. And then we'll test both, and we'll find discrepancies sometimes, and that shows us that they're diverting. So one important thing to look at when you're looking at the screening tests is opiates on the cup are your morphine, your heroin, your codeines, but oxycodone and methadone aren't going to show up on there. The synthetic opiates don't show up as opiates on the testing. So that's another reason why they're going to go to confirmatory testing, where they're going to be able to tease that out. And also fentanyl is not, you have to order, if someone's on fentanyl, you have to order a specific test for fentanyl. It's not on the cups. And I've seen people that are compliant with their medication regimens get fired by their doctors because they said there was no fentanyl in their system, and they had forgotten to order the fentanyl test on the urine drug screen. So keep that in mind when you're looking at fentanyl. So windows of detection. So this is another part where you're wondering, okay, how long do these medications stick around, and how much of a sense of what they're doing am I going to get? And so one thing that's not on here is if someone comes in and tests negative for their medications, you know, if they really did take a medication, how long would you expect to wait until you would find it in their urine sample? And the answer is about 4 hours. So if they've taken that medication within the last 4 hours, it should be showing up in their urine. And as you can see, marijuana or THC shows up, if they're using it chronically, shows up for about a month. The test too, I don't know if it says it on here. The test for heroin, the heroin is, they test something for something called 6-monoacetylmorphine. And the window of detection is very, very narrow for that. So if someone's ingesting heroin and they test positive on your test for 6-monoacetylmorphine, they've had very, very recent use of heroin. So it's something to keep in mind that if you do catch that, that's someone who's probably using heroin pretty regularly. So it's important to look at, not just, what shows up in the urine, but what's not showing up in the urine. So that's, if you're prescribing them a medication and they're testing negative for it, you have to start thinking about where's that medication going. Are they taking too much of it and running out early? Are they selling it? Are you just prescribing it as needed, and maybe because of the other treatments you're doing, they just haven't needed it lately? And what you can do there is if you're testing negative and you're really suspicious, is you can call them in for either a pill count or a random urine test at a time when they're not expecting it, just to make sure that they have the medication and they haven't sold it. But that being said, I don't know if you guys have heard of pill libraries, but some of these the drug dealers actually keep a stock of all the different types of pills, and so if a patient gets called in for a test, they'll count out what their quantity should be, and they'll go over to the pill library and they'll pick up that medication, bring it in, you count it, and then they bring it back to the pill library, and they get, it's very sophisticated. Like I said, people broke out Alcatraz, but at least you're doing the best that you can. Dr. Pra covered this. If you're ever confused, utilize the lab. They're the ones that ran the result. They've got someone that can help you interpret it. I get asked a lot of times if I can point people to a good reference for how to interpret urine drug screens. And I actually I haven't found one to be particularly useful. To me, it's just something that kind of comes with experience and talking to a lot of lab directors and trying to make sense of things. But it's also something I don't know. I think it's such a specialized field that you probably have a lot better things to do than to learn the ins and outs of it, when you can have one of your staff members just call the lab and see what's going on. It's on this slide, I like to talk about a couple other questions that come up frequently. One of them is alcohol. Do we totally ban patients from consuming alcohol? Do we allow occasional alcohol use as long as it's not concurrent with the medication? I think that most of us pain specialists we understand that people may want to have a glass of wine from time to time, and if we test them and they're positive for alcohol and on urine drug testing, we'll talk to the patient about that. You have to look at the circumstances, and there are some, and we're going to get in this later, but there are some of the pain medications will have what's called dose dumping, where alcohol consumed at the same time as the medication it'll break down the long-acting release mechanism, and so they'll get higher levels of that. Morphine's one of them. They'll get higher levels in their system. So certainly if you haven't addressed it with the patient before, that's a great time to revisit it and talk to them about it. And benzodiazepines, that's the other sort of big controversial area right now. And there's some groups in town, pain management groups, that are considering not allowing patients to take benzodiazepines concurrently with being prescribed opiates. Our group right now, basically what we do is we just warn the patients, and we document it in the chart that concurrent benzodiazepine use with opioids, there's no safe way to do it, and it does increase your risk of overdose and death. And I think the statistics I saw before was that it's something like 72% of opioid overdoses involve concurrent use of benzodiazepines. It's a very, very high number. The hard challenge in this situation is just that, you know, benzodiazepines are a legitimate medication. Some people need them. We have a lot of people with PTSD, you know, veterans coming back that are being managed by psychiatry, and benzodiazepines improve their quality of life. So I don't know that it's necessarily my role to tell people that they can't be on benzodiazepines, but I do feel that it's my role to let them know that it's risky. This is the point where if you're at the lecture and you're thinking, okay, I'm going to start venturing into the long-acting opioid prescribing, what I recommend is just picking a couple opiates that you're comfortable with. But we're going to go through some of the sort of contraindications and some caveats with some of the opioids. So keep in mind your patient population. You know, if you treat a lot of patients who have alcoholism, or if you treat a lot of patients that have, you know, cardiac rhythm issues, you know, you can start thinking, okay, if I'm going to use a long-acting opiate, which one of these do I really want to learn inside and out, and which one I would like to use in my practice? So this chart, I think, it's in this lecture several other times, but basically it shows you like the dosing frequency. And so when you look at, if you deal with a lot of patients that have trouble taking, you know, keeping track of their medications, you know, maybe you want to put them on, you know, a patch that you change every few days, or a patch that you change once a week, or something that you only have to take, you know, twice a day. This kind of breaks it down for you, the dosing intervals. One thing that's in here many, many times is not to crush or chew any of the long-acting opioid capsules or tablets, because a lot of the time release mechanisms are affected if you do that. So they'll get a much higher dose right up front if the delivery mechanism is altered by chewing it or consuming alcohol, things like that. The package inserts, they have a version for us, you know, as healthcare professionals that's very technical and goes through pharmacokinetics and all of that. But they also make versions of it that are more patient-centered, that a patient can read and understand. I think those are a great resource. We have a bunch of these printed out, and we keep them in the back. So if I'm starting somebody on a long-acting morphine, you know, we'll give them this handout, and there's another handout that goes through basically, it's gonna, I think in here it comes up later, but it goes through like not sharing your medications with people and things like that. So it's always good to give them information to take home with them, even if the patient doesn't read it, maybe their spouse will. On this slide, I think we talked about how some opiates can prolong the QTC interval. So if you're thinking, you know, if you're a cardiologist, there's, you know, maybe methadone and buprenorphine aren't like the best long-acting opiates for you to use in your practice. And also, opioids in general can reduce the efficacy of diuretics. So it's just something to keep in the back of your mind. One area too that a lot of the opiates are processed by the cytochrome system, the CYP system, that nightmare graph that we had to memorize when we were in medical school. So, do any of you guys do the pharmacogenetic testing? The swabs, yeah, good. So this is where basically only have to have it done once in your life, and I think it's eventually something we're just routinely all of us are going to get. But basically they look at your genetic profile and they can figure out if you've got, if you're rapid metabolizers or slow metabolizers of certain medications. And it's something to keep in mind when you have a patient, especially someone who's had, should have pain relief on the doses of an opiate that they're on. That's a patient that I'll often collect an oral swab sample and send it for the pharmacogenetic testing. And we'll find that, that sometimes that patients are just rapid metabolizers, and when they're telling you my medication only works for an hour or two, that it's backed up by data. And then that's someone that you'll switch to, for example, a non-cytochrome processed medication, and that patient will be very appreciative that you help them. So these are this table is specific drug interactions for, on the left column is all the opiates, and then the ones that interact with, this is another one that's a good one to keep just available to you and maybe, in your office. You can look at, alcohol, P-glycoprotein inhibitors, all the CYP, benzodiazepines, antiarrhythmics. And this can help you choose which of the long-acting opiates that you might want to use in your practice based on your own patient population. This is that graph that we have like an hour to memorize for the post-test. No, I'm just kidding. This is all the CYP things that we forgot from med school. But those are useful because I think if you go through there, you'll see, I think as providers, we tend to use about 30 medications. So a quick look through those tables, you might identify some medications you use frequently, and you might be surprised it might change the way you practice. I think one thing that the authors of the presentation wanted to get across to you is when in doubt, refer to the package insert. The package insert is ultimately, especially for fentanyl and buprenorphine, that's the source where you're going to get drug-specific data. Be sure to assess ongoing need if you're prescribing opiates. Make sure that the patient is benefiting from them more than it's harming them. Document that in there. If you can get a family member that's in the room with them and they're all in agreement with what you're doing, put that in there too. I saw Mrs. Johnson was with her son Mitch, and Mitch is real happy with what's going on. That way later on, if something happens to that patient, it's the family that's gonna be upset with you. And having them be a part of it is really smart. I don't like any other quiz questions in this presentation. This is another slide just about alcohol and crushing and chewing the medication and how that can affect the delivery of the drug, how it can increase and result in rapid absorption of the medication. This is one about if you're prescribing transdermal patches like fentanyl. I'm not a huge, because of the heat in Arizona, I'm not a huge fan of the transdermal applications. I just get a lot of patients that complain that they don't stick and they fall off. And so if you do choose to use them, some of the manufacturers will actually let the patient call the manufacturer and ask for them to send them, tegaderms and things that'll help the patches stick better. So that's something that is usually provided to at no cost to the patient. So it's something you can use to help them. Disposal of these patches, I tell all of the patients that are on fentanyl or buprenorphine patches that when they take that patch off at the end of their dosing interval, there is a lot of medication still left in that patch. And there are people that take the patch off and for some reason they don't think about where they're going to put that patch and they throw it in the garbage can. And then their kids go in the garbage can, and if their kids are like my kids, they put everything that they find into their mouth, and the kids overdose and die. So dispose of the patches, flush them down the toilet, don't leave them where kids can get to them. Constipation, this is probably the most common side effect that you're going to hear about when you have someone on opiates. It doesn't get better. So whatever it is that day when they're complaining, it's going to stay the same. You can either switch them to another opiate and see if it's still as bad as it was with the first opiate, or you can just get them on a bowel regimen. Stool softener and a laxative, the vast majority of patients do do fine with that type of a regimen. Watch for sedation. Tell the family members if the patient seems sedated that, when to call 911, when to call you. A lot of these are in this lecture several times just because these are the really important things they want to get across. These are your concurrent use. Any of these medications or substances can potentiate respiratory depression and lead to overdose and death. Remember, when you're going to reduce the initial dose if someone's already on one of those medications and there's nothing you can do about it, you may not start that person on as much opiate as you would start somebody else. You might say, well, normally I'd start you on a 10 milligram Percocet, but for you, because you're on all these other things, we're going to start you on a 5, and then you're going to talk to them about the risks. These we've all gone through. Methadone, buprenorphine, again, antiarrhythmics, QTC prolongation. So CYP inhibiting medications will increase opiate levels because they're not able to process those drugs through the normal metabolic pathway as well. This is a good one that just shows the drug and the potential risk. We talked about all of these already: dose dumping, respiratory depression, serotonin. So I think this one's in your test somewhere. Products, remember we talked about opioid tolerant and opioid naive. Transdermal fentanyl patches and long-acting hydromorphone preparations. Like Exalgo is the brand name of that. Those you're only going to start someone on that if they're already on those specific doses of opiates that were in that slide in the very beginning of the lecture for 1 week or more. The other thing I want to talk about that is something that isn't in the presentation, but it is a side effect of opiates that isn't really addressed is the hypogonadism, the endocrine effects of opiates. And so these are basically, it's the opiates, especially long-acting opiates, actually will inhibit the release of gonadotropic releasing hormone, and so this will in men eventually cause low testosterone. And they've studied men that are on long-acting opiates, and it's close to 70% of men on long-acting opiates will have a low testosterone. And so, this is one of those things that's gonna happen, and usually it's the wife dragging the husband into the office and complaining about fatigue and low libido, and no one's ever told them that this is gonna lower their testosterone. So if you tell a male that you're going to start them on something that's going to lower their testosterone, they're going to be much more likely to want to do physical therapy or OMT or chiropractic or something else. So, it's something I bring up a lot of times on the first visit. And if they notice it and the opiates are helping them, they can supplement it with testosterone supplementation. I get asked a lot about. You hear about tooth loss with opiates. Does anyone, ever hear the story like, Grandma Emma lost all her teeth after going on the morphine? So the reason that happens is just because the opiates cause dry mouth, and they get more cavities and they lose their teeth. So it's not something that is in the drug that attacks their calcium in their teeth or anything like that. The way around it is good dental hygiene. And frequent, keeping your mouth wet with water and things like that. All right, that was Module 5. Pretty good, huh? Okay. So we're going to go to Module 6. Module 6 is where we get into the really nitty-gritty product-specific things, and we're going to apply through this as well. This is a graph that shows relative potency of the opiates. So some are stronger than others. So you got morphine on the far left, and you have fentanyl patches on the far right. So it just kind of shows you that there's apples and oranges, and some of them are stronger than others. You know, you got your Zohydro, the long-acting hydrocodone. Well, you know, it's hydrocodone is going to be right in between morphine and oxycodone. Yeah, I haven't prescribed anybody that yet. I don't know if you're seeing a lot of that out there. You know, and methadone and buprenorphine and tapentadol, which is Nucynta, they're not really known well enough to put them on this chart. Okay, this is a fairly useful graph. In the middle shows you what you would start somebody on if you wanted to start somebody on a long-acting opiate. On the left side, it has all the long-acting opiate formulations, and in the middle, here's where you would start them on the dose. And then on the right side is if people who are used to opiates already, that already meet that criteria we talked about earlier, that's where you would start them and what intervals you could titrate them at from a dosing perspective. So this is a pretty useful chart. I'm not going to go through each of those in there. This is another bad question. That slide is basically just saying if you treat a lot of alcoholics, what medications would you avoid? And we're going to get to that, but morphine, Opana, and Nucynta are all ones you'd avoid with someone that might ingest alcohol. So this goes through, so like morphine, sulfate, there's a couple different formulations or brands, I guess would be a better word. And this goes through and talks about the differences between the brands. So, you know, Avinza is one medication if you have people that have trouble swallowing big pills, but they need long-acting morphine. These you can open up the capsule and sprinkle them into applesauce. So, you know, if you see a lot of hospice patients that, you know, maybe have had gastric bypass surgery and they just can't tolerate pills very well, this would be useful in those people. All of the morphine formulations are avoid alcohol. That might be on your test somewhere as well. Cadian is another brand of long-acting morphine, and it has the same benefit with being able to open it and sprinkle it onto applesauce. I'll mention as far as long-acting preparations of the medications go, morphine is one that you can actually dose 3 times a day instead of twice a day. You know, OxyContin we look at as just a BID medication. So what I do is if I'm prescribing someone morphine and they'll come in and tell you, you know, you put me on this long-acting morphine and I'm just in the middle of the day, pain is much worse and I'm not getting any relief and I can't function, you just add a TID dose on there. So a lot of people do fine with BID dosing. The TID dosing just gives you an option if they come back and they're not well controlled. And you can adjust the dose. If you're really trying to quickly get someone under better pain control, you can adjust it in every 2 days. So you could see them back frequently in your clinic and bump their doses up. Embeta was an interesting concept. They mixed a long-acting morphine preparation with naltrexone. But what they found was that there were some problems in the drug delivery system, and it was precipitating acute opiate withdrawal when people would take it. The idea was it would be an abuse deterrent, so if they crushed it or chewed it, then they would get all their opiates would be reversed. And so they took it off the market, but it's expected to be back on the market sometime soon. They've apparently rectified the problem. OxyContin, this is one that you know, if you're doing a fair amount of pain management, you're going to want to be familiar with OxyContin. Probably morphine, OxyContin, and fentanyl are the ones that are covered by the most payers. So if you're going to prescribe a lot of long-actings, those would be ones you'd want to be familiar with. OxyContin, they have some patients will complain that there'll be ghosts of the tablets in their stool. That's okay. That's normal. That happens, but it's something you can tell them to expect, and they won't freak out too much. So the tablets are a little bit harder to swallow. So again, if you have patients that have gastric bypass or esophageal issues, OxyContin may not be a great choice for them. And also, if they have liver or renal impairment, you're going to reduce the doses on OxyContin. And frequently with the PGT testing, the pharmacogenetic testing, you'll find people that are rapid metabolizers. So if, in my practice, we don't prescribe OxyContin more than twice a day unless we've shown that they're a rapid metabolizer of the medication, and then you can justify it in that scenario. So Opana is oxymorphone, which is one of the active part of oxycodone gets processed into oxymorphone, and oxymorphone is what gives them the pain relief. And so oxymorphone is a more potent version of OxyContin. The clinical pearl that they want you to take away is that some people do better with asymmetric dosing, and that just means that you'll have patients say, well, I do really well with one during the day, but I might need 2 of them at night, or the opposite, maybe I need 2 in the morning and 1 at night. And that's okay, that's commonly reported with that medication. And the generic form is not abuse deterrent with oxymorphone. Exalgo is the long-acting hydromorphone. That was one of the ones that you would not start an opioid-naive patient on that medication because of its potency. And patients who have sulfite allergies can have side effects with that medication. And it's not sulfa, it's sulfites, like all the food preservatives and things like that. So methadone, I'm seeing a little bit of a resurgence in methadone, and it kind of concerns me because a lot of the payers are driving it with the pricing. They're trying to encourage us to put people on methadone instead of other long-acting medications. And the reason is cost. Methadone's very cheap. But the problem is that it comprises something like 2% of opioid prescriptions in the country, but it's responsible for 33% of the deaths. So if we're going to take an already huge opioid problem in this country and convert everybody over to methadone, the deaths are just going to go up. They're not going to go down. So it's a medication that with careful use and monitoring, it's a good medication, especially for people that have that burning neuropathic pain because it has some NMDA receptor activity. But it's not something that would be my go-to drug. We prescribe very little of it. I rarely start a patient on it. So be very careful with this one. And it's the one when you rotate from one to another, it's a 75 to 90% reduction. The half-life of the medication is very long, and so if the patient's not a reliable patient and they overtake their medications, and you say, well, I'm going to put you on methadone because I hear that's good for people that are addicted to medications, they'll keep taking it and taking it and taking it, waiting for that pain relief to happen, and then 5-6 days later, they're going to overdose because they got the pain relief, but the respiratory depression is still present. And people can still get addicted to methadone. The rapper Eminem, he was addicted to methadone. Well, I guess still is when you think about it. Nucynta is a newer medication. It has the alcohol warning on it as well. And this one can also be associated with serotonin syndrome. And we don't really know what the efficacy comparison is with morphine. In my practice, I really use it for people that are just, we've kind of tried all the ones that are covered by their insurance well, and they're still not getting relief. We'll try Nucynta. It tends to be a little bit more expensive on their drug tiers, at least for now. But I've seen patients do very well with it. Butrans is the transdermal patch. Patients wear it for 1 week at a time. So this is, I like this one for someone who might be in like an assisted living or care facility where maybe their kids only are able to go and see them on the weekends, and they're not too sure if the patient can be compliant with taking a medication once or twice or 3 times a day, especially a medicine that could potentially be lethal. So we put them on this patch, and you change it once a week. So that's where I really utilize this in my practice. And because of the way that the medication works, if patients are already on traditional opiates, if you put them on a buprenorphine formulation, the buprenorphine is basically kind of takes over, and the other opiates it's not as responsive. So you'd have to give them higher doses of opiates for the, like if you were going to give them like a breakthrough pain medication, because of the inhibition that the buprenorphine causes on the receptors. Fentanyl patches, we talked about proper disposal of them, being very careful in opioid naive patients. There are some patients who will say that the fentanyl patches don't work very well on the third day. And the way that the fentanyl patches are released in, the medication's released in your system, if you're very thin and you don't have a lot of body fat, it will indeed not work very well on the third day for those patients. So you may sometimes find that you'll have to prescribe them to change the patches every 2 days instead of every 72 hours. I think fentanyl patches, in my personal opinion, are one of the hardest to wean people off of. I think people they like the feeling when they're on it, and it's always a challenge when it's time to try to get somebody off the fentanyl patches. The dose I think of when you look at that 200 milligram morphine equivalence, where the risks really go up with the opiates, equates to about a 50 microgram fentanyl patch. And when I first came to Phoenix, I would routinely see people on 100, 150, 200 microgram per hour fentanyl patches. So, and that one, you think about the dosing, like a 200 micrograms of fentanyl in an hour is that's a boatload of fentanyl. I mean, in the OR, before they crack the patient's chest to do open heart surgery, we give like a 250 microgram push, and then they crack their chest. And the fact that someone is on that every hour just blows my mind. But it is an effective medication, so
Think about the instant spray fentanyl.
Yeah, so
That's just come out now.
yeah, there's a lot of like intranasal fentanyl sprays and things like that. They're more for, in my opinion, more for people that are, in cancer pain, later stages of life. Their pain comes on really fast, and you want to catch it early. I don't know if did you guys ever heard of the medication Actique? Did you ever hear? These were fentanyl lollipops. Take patients with non-cancer pain who already have this abuse and addiction potential, and send them home with a big bag of lollipops of the instant fentanyl high. So this is really not a lot different. It's just a different dosing route, essentially. So I'm leery about it. I mean, I have reps in my office probably once a week trying to get us to use more of those, and I really just reserve it for cancer pain. That is it.